This podcast includes a discussion of investigational therapies whose safety and effectiveness have not been evaluated by any regulatory agency. The experience of any patient in the clinical trial discussed during this segment may not represent the experience of all patients who received this investigational agent as part of a clinical trial. Always speak with your doctor about whether a clinical trial is right for you. Hey everybody, welcome back to the I Believe podcast. I'm joined today with Sush Patel from Replimune, and you guys, I am so excited to talk to him and to talk to the Replimune team. I have been itching to tell you about Replimune and about the trial that they have coming for the last 2 years since I actually ran into one of their team members at Sacco in 2022. So I'm thrilled to have Dr. Patel with us. Dr. Patel, can you tell us about some of the exciting things you have coming for uveal? Give us some hints.
Thank you for that kind introduction, Danet. It's a very busy time at Replimune, and actually we're particularly excited that we're actually moving forward with RP2, which is the second oncolytic viral product we have in our portfolio in metastatic uveal melanoma.
Let's talk a little more about how Replimune got started.
Replimune was originally formed in 2015, and our whole sort of reason for being a mission is to really develop and design the next generation of oncolytic viruses, really trying to drive not only a local activity with this modality, but really drive systemic immune activation. The company was originally formed by some of the founders who actually launched the first oncolytic virus in the marketplace in melanoma many years ago. That was a great first step, but the whole idea of how can we develop and design more potent and systemic oncolytic viruses, and that's what we're doing with RP1, which is our first product, which is going to be in skin cancer. And then RP2 is the product that we're going to be talking about today.
It's so exciting. Obviously, somewhere you guys ended up working not just in skin cancer, but in uveal. We're such a rare cancer. Can you just give us an idea of how you ended up in our neck of the woods?
Yeah, a little bit of serendipity. One of the areas that I think we know in all cancers that's hard to treat is liver and liver metastases. When we were doing some of the studies with RP1, our first candidate, we had seen some activity in various cancer types with patients who had liver metastases. Seen some potential signals, including in uveal melanoma patients, but we know it's a difficult to treat disease. And so we thought, well, actually, RP2 is designed to be even more potent than RP1. Why don't we do some more work with RP2 in uveal? And at that time, we enrolled a few patients, saw some interesting signs of activity, and so expanded that trial. So we had ultimately 17 patients with uveal melanoma, and we saw a 30% response rate, which was obviously very exciting. And in addition to that, we saw almost a 60% disease control rate. So not only did patients respond, but another 30 or so percent got into stable disease. Because of the modality, it's a local administration into the tumor.
No, that's so exciting. And I love hearing about these response rates. And for our listeners, you guys, a response rate, and actually, Sush, do you want to just give us a little bit of a background? What is response rate versus disease control rate?
So as we think about response, there's a sort of criteria that I think we use in everyday practice of, is your tumor shrinking? Then there's what the FDA and we use in clinical trials is a RECIST defined criteria, and that's typically defined by does the tumor, the sum of the diameter of the overall tumor, shrink more than 30%? So that's considered a formal response. So when we say we've had a 30% response, that means that 30% of patients had their tumor shrink 30% or more in the 17 patients that we enrolled. Early data, but obviously very exciting, and that's what really drove us to move forward with this registrational trial that I mentioned.
As far as those 17 patients that you had, did you guys notice any common side effects with the initial dosing?
These are very typical side effects we see with this modality because we locally inject, we do see fevers, chills, some fatigue, some hypertension, really signs of immune system activation, which is what we want to see. We want to see that the virus is going in there, lysing the tumor, and then as the tumor sort of releases its neoantigens, then the patient's immune system can start to recognize the tumor. And that's when you see these kind of constitutional symptoms that are quite common for modality.
So you said lysing the tumor, is that what you said?
So we have an oncolytic virus, and it's based on HSV1, and it's been designed to selectively replicate in cancer, but not healthy tissues. We make some modifications. And so what happens is when we inject the tumor with the virus, it actually breaks down the cancer cell. And when I say lyse, that's what I mean by sort of breaking down, lysing the cancer cell, breaking it open, degrading it. That releases the antigens that previously the immune system couldn't see in the tumor. They're often hidden from the immune system. So that's when the immune system can kick in, and then you get that systemic sort of immune activation that we all want to see.
Okay, so let's talk about the systemic response, because this is something that I find so fascinating. In kind of the data that I heard from some of your team members at ASCO, they were just talking about how the idea was that they could basically treat, for example, a tumor that was maybe on the surface of the skin, but they would inject that tumor and then they would follow the rest of the body and they could see response in the rest of the body. Is that what you mean by like a distant effect?
That's exactly right. As I mentioned, the first sort of oncolytic virus was out there. We definitely saw that when you injected a tumor, if you had like a superficial lesion of a skin cancer, that worked. That would work quite nicely, but it was sort of a limited amount of systemic activity. So you may see very little sort of response in any cancer that spread to other organs, for example, liver or lung. Whereas with RP1 and RP2, what's really encouraging and I think exciting both in melanoma and uveal melanoma is we're seeing these responses. Even when you inject at a local lesion, we see systemic responses quite far away from the site of injection. So that could include all kinds of organs where we see responses, including liver, which is why we were so excited about doing a uveal study.
Just for our listeners, you guys are probably wondering, okay, well, most of our metastatic lesions originate in the liver. So is it possible for you guys to use the RP2 to inject directly into the liver? Is that the goal of the study? Or,
yeah.
Okay.
So as you well know, that a large percentage of uveal melanoma does metastasize to the liver. And what we've been able to do with using interventional radiology colleagues is they are able to safely and reproducibly inject liver. And I think that's great because you have, as I mentioned, you have that local activity as well as then driving that broader systemic response that we want to see in clearing up the cancer more broadly in the body. So yes, we've been able to do that. And we've done that with RP2 in a number of patients, and you can do repeat liver injections safely and reproducibly, which again, quite nice to see because there's always a concern of, when you're injecting my liver multiple times. But because we have a very thin needle, it's not like a liver biopsy where you can sometimes have bleeds. We have a very low incidence of bleeding, shown that you can do this reproducibly and safely, which obviously is important.
Oh, this is so exciting. So I'm going to assume that probably an interventional radiologist would be involved in something like this. Let's get back to patients. I know you guys have a really interesting story from Dr. Joseph Sacco in the UK. So do you want to talk to us a little about the patient Lorraine that you were telling me about?
Dr. Sacco was one of the lead investigators on that phase 1 trial. I mentioned the 17 patients and the data, and one of his patients, Lorraine, and at Replimune, what sort of drives us and gets us most excited is when we hear these patient stories. And she was selected for actually an interview with one of the large TV networks in the UK called ITV. And in that interview, she just talked about what a life-changing experience it was for her because she went from having a very bad diagnosis and outcome, given that she'd had pretty broad liver involvement, to actually then seeing very significant reduction in her liver metastases and feeling so much better that she could sort of go away from focusing on the cancer to really focusing on the things that she really wanted to do. And that was very inspiring to us. And clearly another reason why we wanted to provide this option and really look at how do we bring RP2 forward for more patients. If you want more information, if you go to our website, we have a corporate deck where you can go to the ct.gov listing of the trial site. Certainly our website's a good source of information. I'm also happy to forward you the link if you want to put it on any of your materials.
Yeah, I would love to. Just for our listeners, you guys, we'll have links in the show notes, in the description on YouTube. Anywhere you can find a link, we're going to make sure that you have access to this link directly to the clinicaltrial.gov page, as well as just any of the sites. Keep an eye on this. Keep an eye on clinicaltrials.gov. Definitely join our newsletter so you can stay in the know. We're so grateful for your time today. Is there anything else that you want to share, just kind of as we close out?
Thanks for the opportunity and thank you for everything you're doing for uveal melanoma patients. I'm actually personally very excited because you just see the amount of activity and development now happening in uveal, which wasn't the case just a few years ago. And I think that's great for patients, and we're very excited to be part of that journey with you. So
I feel so lucky as a patient to be in the position that I am, where I get to talk with people like you and I get to learn from the experts who are kind of new in the upcoming research, because I get to know about some of this stuff years before it even is really relevant for the community. I have been so excited for this trial for like 2 years. This is one that I will gladly be like, sign me up, because like I love this idea and it makes tons of sense to me in the terms of like the science of the immune system. If you want to go back and listen to one of our episodes about the immune system, we had one of the patients, Lucy Innes, who's a researcher. She's researching the immune system. She talks to you about what is the immune system for and how does it function. It all just really fits fits right in with the how does the immune system work? And it is literally the most exciting stuff. I could geek out on this all day. Anyway, so thank you, Sush, for your time. Thank you, Replimune, for just providing this trial for patients and for continuing to really just be as excited and driven to make sure that uveal patients have opportunities for treatments like this. So we're so grateful to you guys. Those of you listening, please make sure to subscribe, share this with somebody else so that we can get the news out. Make sure you tell your oncologist, have them listen to this podcast, have them listen to the YouTube and share it with other people.